Good afternoon. My name is Angela Bader, and my lecture this afternoon is called Improving Value in Healthcare, Geriatric Surgical Patients. My objectives for the lecture, first of all, I'm going to define value in healthcare. Secondly, I'm going to define how we measure value, including what metrics we can use to measure quality and patient-centered outcomes, as well as the cost of providing those outcomes. Thirdly, I'm going to introduce you to time-driven activity-based costing and process maps, which are a great methodology for mapping value. And finally, thinking about how we can apply these value-based principles to geriatric surgery. First of all, what is value? This slide is from 2014 and defines the triple aim, which is how do we improve healthcare outcomes. The triple aim includes improving the individual experience of care, improving the health of populations, and reducing the per capita cost of care for populations. So you can see, regardless of whether it's medical or surgical care, we need to think about not just the individual experience, but the overall health of the population in terms of surgical or medical care. So how do we define value? We tend to focus on quality. However, value is quality over cost. How do we define quality and cost? The quality of care is patient-centered outcomes, and the cost of care is the cost of achieving these outcomes. And this concept comes from a book called Redefining Healthcare by Porter and Teesberg. And if anyone is interested in going into this methodology in more depth, I would highly recommend this book. How do we look at value when we think about our fee-for-service models versus a value-based model? In fee-for-service, we really don't know the cost of providing the total care. For example, what is the total cost of a geriatric hip replacement or a geriatric knee replacement? We really don't know these numbers, and it's very hard to calculate them. Cost, therefore, does not equal charges, which are often based off a hospital's charge plate or some standard charge methodology. They're submitted to a variety of insurance companies, and these charges don't equal the revenue we receive. In fact, the revenue may be different for the same procedure, depending on which insurance company is involved. So this is our current fee-for-service model. In a value-based model, you would hope to be able to measure outcomes and true cost so that you can really determine the value of the care provided. Patient-centered outcomes over cost equals value, and then perhaps, as you'll see later in this lecture, we can negotiate with insurance companies based on true cost and true value. Traditional surgical and anesthesia outcomes are arbitrary. For example, 30-day morbidity and mortality, giving antibiotics within 60 minutes of incision are really not patient-centered outcomes. We use these kind of metrics because they're easy to measure. For example, process metrics are first case on time starts, turnover time, number of cases done in a day. Not only are these not patient-centered outcomes, they're really process and not outcome metrics. What we really need to think about in terms of patient-centered outcomes is what is the impact on health trajectory and the patient experience. For example, in this slide, let's take, for example, line A, where we're looking at the health trajectory of a patient. Perhaps he has increasing hip issues and his quality of life is deteriorating. until he gets to a point at time zero where he is contemplating surgery. Now, we would hope that surgery will get him back to his baseline. However, elderly patients can have cognitive issues perioperatively. And if we don't carefully think about these outcomes and the impact of the perioperative care plan on these outcomes, you might see deterioration in postoperative cognitive trajectories. So, in a fee for service model where we have a volume incentives, we really want to do a shift where we're thinking about paying for outcomes and a value incentive. If the incentives are changing, then our strategy and behavior must change as well. It's time to break the silo mentality in healthcare. Instead of thinking about care in a vertical way, we need to think about care in terms of the patient's care trajectory in an episodic way. Instead of silos, for example, the silo of the pre-op clinic, the silo of the surgeon's office, the silo of the postoperative recovery unit, we need to think about high collaboration and results-oriented care in which all of the care is focused on the patient and we develop an episodic care plan. So in this shift from volume to value-based care, we go from fragmented providers and payments to collaboration and connectivity, from no uniform quality to an analysis which tries to standardize to the best practice models. Instead of fees for volume, we try to optimize outcomes and provide value. And as the demand for volume is increasing, we think about accountable care. How do we think about these care pathways, and what is the benefit of shifting from silos to longitudinal care pathways? The benefits are we can reduce variations in care from case to case and consultant to consultant in the same department, because we facilitate the introduction of local protocols based on research evidence into clinical practice. We encourage multidisciplinary communication and care planning. The use of these best practice protocols enables new staff to quickly learn the key interventions for specific conditions and to appreciate the impact of patient variation. And we embed a clinical audit into daily practice, so we really measure how well we're following these protocols and the value of the care we provide. So when we talk about the future of healthcare delivery, and particularly geriatric care, we want to think about organizing geriatric care into value-based integrated practice units. What is an integrated practice unit? So an integrated practice unit for geriatric surgery would be a set of multidisciplinary team members that organize around a medical condition. For example, geriatric surgery, perhaps geriatric orthopedic surgery, a set of closely related conditions. Care is delivered by a dedicated multidisciplinary team of clinicians. The team takes responsibility for the full cycle of care, outpatient, inpatient, and post-op. Patient education, engagement, and follow-up are integrated into care. The team measures outcomes, costs, and processes for each patient using a common measurement platform. And the providers on the team meet formally and informally on a regular basis to discuss patients, processes, and results. Joint accountability is accepted for outcomes and costs. We would therefore define this type of care as an episode of care. An episode of care is defined as all the care that occurs from when the episode is triggered. For example, you could define that as when the patient is referred to a surgeon for an orthopedic procedure, through the preoperative evaluation, inpatient care, and outpatient recovery. And the bundle is what the insurance company will provide the institution for providing all aspects of that care. So instead of our current fee-for-service system in which there are silos and all of this care is partitioned, the care is considered as an entire episode, and the bundle includes all the care from pre-op through post-acute care, whether it's inpatient, outpatient, whether it's rehab, home health care services, prescriptions. And this is going to be requiring a lot of work to think about how do we define these episodes and how are we sure that we're including in the bundle all the care that's going to be necessary to get this patient successfully through the episode. This is going to require appropriate patient selection, risk-benefit discussions, and optimization, all of which are key things that anesthesiologists can help provide. These things will be key as pre-op resources and optimization may reduce post-operative and post-discharge costs and improve outcomes. And that's the shift from volume to value. So that's the organization into an integrated practice unit, and that's how it fits with this concept of episodes and bundles. Second piece of this is what outcomes should we measure? How do we define the numerator of the equation? Michael Porter's group at Harvard Business School started an organization called ICHOM, which is an international consortium of health outcomes measurement. These things are free on the web for everyone to take advantage of, and they are defining an outcome measures hierarchy for certain conditions. And for each condition, they define the outcomes as tier 1, tier 2, and tier 3, where tier 1 are the survival outcomes, which are our typical morbidity and mortality outcomes. Tier 2 are the process of recovery outcomes, including time to recovery, time to return to normal functions, and any disutility of care, including diagnostic errors, ineffective care, treatment-related discomfort, etc. Tier 3 outcomes are the sustainability of health. For example, when that patient recovers from the surgery, from that hip surgery, for example, is their recovery sustained? Why are these type of pathways important for payment? So we've talked about changing from volume to value, looking at bundles, looking at episodes, thinking about different hierarchies of outcomes. Well, insurance companies, particularly Medicare, is becoming increasingly committed towards quality-based payments. And this slide shows for both medical and surgical conditions, Medicare has a number of programs which are shifting towards value-based payments. So we need to start thinking about this as anesthesiologists and working with our hospitals and institutions and coming to the table in multidisciplinary ways to think about these new ways of defining value and how payment will be based on these new ways. Here is one example. Medicare, the Center for Medicare and Medicaid Services, or CMS, started a comprehensive care for joint replacement model. This piloted in 2016. And what Medicare did is for total joint replacements, they defined the episode as the time of referral to 90 days post-discharge. And Medicare defined all the care provided during that episode, whether it would be under Medicare Type A, Type B, outpatient, inpatient, prescriptions, rehab, etc. All of that care is included in this comprehensive care model. 800 hospitals were in this initial pilot, and Medicare included these hospitals with the ability to, if the hospital did not have any margin after providing the care in this episodic based model in which Medicare paid one bundle for all of this care to the institution, Medicare would make up the difference. So it was a way of hospitals to experiment with how could they bring everyone to the table to meet this comprehensive care pilot successfully. In the New England Journal in 2019, Medicare published the first results of this pilot. And in the 800 hospitals who participated, I'm not going to go into detail into all the numbers, but what they found is providing care in this way, defining this episode, and paying the institution one bundle for all the care provided out to 90 days post-discharge. They did not see any reduction in quality metrics, but they did see significant cost savings based on a reduction in need for post-discharge care. There was a decrease in skilled nursing facility use and a decrease in inpatient rehab use, which accounted for a lot of the savings. As anesthesiologists, we can play a key role in these models by becoming a major part of optimization, pain management, preoperative risk management, and all of this can help contribute to the value of the care provided under these models. So we've talked about now what an integrated practice unit is, how that can be defined as an episode of care, and a bundle being the money that an institution receives for that care. And then we talked about an example in geriatric surgery, the Medicare pilot for joint replacement, and how outcomes can be measured. How do we measure costs, which are the denominator of the value equation? I would highly recommend this article by Porter and Lee, which was in the Harvard Business Review in October of 2013. And what they propose is a strategy called TDABC, or time-driven activity-based costing, which provides the ability to conduct the cost calculations that will help you assess value. We published this article in the New England Journal Catalyst, and what we did was use this methodology to look at triage in the endoscopy suite. And the good thing about time-driven activity-based costing is that it's kind of like organic chemistry. The symbols are the same no matter who uses the process. So the overall care cycle, which is the blue rectangles, is basically each rectangle has a step in the overall care cycle. You then can take any one of these rectangles and use detailed process mapping. A diamond is a triage point or a decision, and the pink rectangles are a person or someone who is performing the task, and the little circles are the time it takes. So, for example, the first diamond is the triage between an ambulatory site for the endoscopy and the main hospital site for the endoscopy. And then once you make that decision, then you decide, for example, at the ambulatory site, is that patient going to be triaged to get just sedation, or is he going to be triaged to have anesthesia involvement? A scheduler, the pink rectangle, is the one using protocols to make these decisions, and it takes about 10 minutes. So by using this, you can calculate the cost of your personnel. You know how many schedulers you need. You know the volume going through the system. And I won't be going into detail into the details of this, but you get the general idea of how process mapping works and how you can use it to calculate the costs of a process. You can continue to map the entire endoscopy process, including clinician time, turnover time, etc., and the cost of the personnel providing the various processes. So this is a way that is proposed to calculate the denominator or the cost factor in the value equation for any specific process. Using this kind of methodology, you can change elements in that diagram and see what happens, for example, if you shift more volume to the ambulatory center, if you shift more volume to the main hospital. For example, if you can shift more volume to the ambulatory center, in our case, you could decrease the wait for appointments with anesthesia from 3 months to 3 weeks. And that information is all in this article in Harvard Catalyst that we wrote, if anyone is interested in more of the details. Now, in general, what this would require is mapping out the entire preoperative pathway for an episode of geriatric care, from the referral through the surgeon's office visit, and using similar triage algorithms to decide who could be evaluated by phone, who needs a clinic visit, is it a routine visit, do they need special pathway assignment because they are defined as frail, cognitively impaired, do they have other medical comorbidities that would require further pathways and protocols, such as diabetes, pre-op anemia pathways, etc. Are there special issues requiring specific discussions, such as DNR, DNI? So it may seem complex, but it really is a way of standardizing to the highest level the way of dealing with geriatric patients, for example, and their specific comorbidities and needs. We published, there's an article in Anesthesia and Analgesia in 2018 that looked at, this is from the Duke group with Saul Aronson, applying this directly to geriatric surgery. And Duke has done a very great job of implementing a perioperative medicine model for population health. And what they did was they defined all the possible things, the comorbidities that could be optimized preoperatively, and operational protocols. For example, they have preoperative anemia protocols, preoperative diabetes protocols, etc. And they are increasing the number of protocols so that more and more of them will become operational. What used to happen was that patients went to a surgery clinic and then were referred to either phone screen or clinic visits without standard optimization. But as this slide shows, the patients that are referred to a pre-op clinic are then looked at in terms of whether or not optimization is needed, and then referred to the various subclinics. One of the subclinics that you can see in this model is the POSH clinic, which is perioperative optimization of senior health. This slide is from Duke and looks at their perioperative optimization of senior health pathway, which they have basically taken all of the ideas which I have discussed in this lecture and applied this to a very detailed geriatric surgical pathway that includes detailed attention to specific geriatric comorbidities such as cognitive issues, frailty issues, etc. I'm not going to go into details here. Obviously, it's a complex pathway, but this information is available. And if you're interested in thinking about developing similar geriatric pathways, this information is available in published manuscripts. Duke also uses this for marketing. Its POSH initiative is rapidly expanding, and they have shown significant positive outcome metrics. For example, geriatric patients that go through the POSH program demonstrate a 2-day reduction in length of hospital stay and a 7% decrease in hospital readmissions at 7 days and an 11% decrease at 30 days. So Duke is able to show that the resources that go into this program result in significant increase in value by optimizing patient experience, patient outcomes, and decreasing the cost of the episode by decreasing length of stay as well as readmissions at 7 and 30 days. Also, more patients have been shown to go home rather than to a facility or home with services as a result of enrollment in the POSH program. So you can see the significant positive outcomes. The American College of Surgeons in 2019 developed and proposed implementation of what they call optimal resources for geriatric surgery, which is a set of standards for certification as a geriatric surgery center. These standards, in a way, are following the Duke model of looking at everything from the beginning of referral to discharge and post-discharge. And we are one of the institutions that is attempting to achieve certification by meeting these standards. Just looking at our own gaps, there are a number of gaps that we at the Brigham are trying to overcome. And we actually now are in the process of submitting for certification. So we have developed implementation processes for these pathways, looking at things like routine frailty assessment, routine cognitive assessment, delirium prevention, early mobility, fall prevention. And so one way to think about this is, as an institution, identifying your individual gaps and thinking about how you would need to overcome these gaps to achieve certification. To do that, we have developed a Center for Geriatric Surgery that includes surgery, geriatrics, palliative care, anesthesia, nursing, hospital administration. And our mission is to deliver personalized, high-value care through the entire surgical episode to these geriatric patients using multidisciplinary input and clinical, operational, and financial metrics. We're in the process of development, and we have published a number of articles that will enable us, hopefully, to achieve these goals. We include rehab, and we try to look at prehab and intervention. So I hope this talk has helped with your understanding of this, and I'd be happy to answer any questions during the question and answer session. Thank you.